one.
Hi, my name is Dr. Jack Einhaber, and this is the second of 3 videos. The purpose of these videos are to present a healthcare alternative that I believe will be universally acceptable and will reduce many of the problems we have in medicine, not just in the United States but worldwide. It'll make medicine much more efficient, reduce costs, very importantly, reduce medical error, and make healthcare affordably available to many, many more persons. High quality healthcare. So last time I was talking about some of the background for this proposal that I've got. And I formed a lot of this out of desperation. I've been hospitalized about 1.5 years out of my life, been told half a dozen times that I'm going to die within 5 years to a few weeks, actually. And I've had extremely difficult major surgeries, including a liver transplant. Actually had more than 100 different kinds of surgeries. And not 100 different types, but more than 100 surgeries of several different types. And I've been hospitalized in many cities, at many hospitals, in quite a few states, and several different countries. Now, what I noticed, and I had lots of time to do noticing as a patient, what I noticed was that even the finest, most competent, most brilliant doctors are often inconsistent. So they would come in and tell me one thing one time and tell me something quite different another time. Or I would repeat some symptoms and they would come to different conclusions at different times. And so I said to myself, well, you know, there has to be a way to deal with this phenomenon. And obviously, they can't be right each time. Because some of these conclusions they came to or suggestions they made were contradictory. Now, that's not even to mention the disagreements between different doctors, because there's plenty of that. So, and of course, this is natural to human beings. We have a lot of inter-individual differences, so that's differences between ourselves and other persons. But there's also intra-individual differences. Differences in our own concepts or behaviors from time to time. A good example is performance at a foul line on a basketball court. Now, if we standardize the conditions, we're there at the same time of day, during the same weather, with the same ambient or environmental conditions, but at different times. And one time we'll take 10 shots and we'll get 2 out of 10. We'll perform miserably. And another time, same conditions, we'll get at that foul line and we can't do anything wrong. We'll get 9 out of 10. Well, what's the difference? There's so many variables or individual situations that can account for these differences. I won't go into details of synchrony in nerve firing and whatnot, but some of it might have to do with that. Now, so I came up with the system in which essentially, just to reiterate or repeat, essentially a patient will have symptoms or will be due for an annual checkup and will be asked to come up with any symptoms that they have. And before the meeting with the doctor, before the doctor's visit, the patient will fill out a questionnaire And in this program that we've got, there's flexibility. So if people would rather do it with an audio tape or a videotape, that can also be done, as long as the symptoms are documented. And we'll have support staff and a helpline and other ways in which to document these symptoms. Now, the symptoms will then be filtered through a computerized database of our existent diagnostic knowledge. And I should mention that there will be incentives for patients to complete this. There will be financial incentives, because this program should reduce the amount of time during medical visits. It'll save the doctor from having to probe. It'll save the doctor from having to think of something later, because the computer will come up with a much more comprehensive and error-free plan for the patient. So what will happen is, you've got these symptoms, they'll be filtered through this diagnostic database. And the result will be cross-referenced with the patient's own medical history. Now, I don't know if I mentioned before, but the questionnaire will be culturally oriented and available in different languages, so that we can get a much better idea, much better, more accurate idea of what these symptoms really are. You know, is it a sharp pain? Is it a dull pain? Does it come in the morning? Does it come in the afternoon more? Does it come and go? Is it constant? That sort of thing. So I'll give you an example of how this might work. The patient might come in with right lower quadrant pain. So that's pain below the navel or the belly button on the right side, or in that area. And there'll be several different candidate causes for these symptoms. But one obvious one is appendicitis. So here's the symptom: right lower quadrant pain, and then it is filtered through the database, and the database comes up with, it might be gastroenteritis, an inflammation, in other words, an inflammation of the stomach and intestines, problem with the cecum, where the small intestine interfaces with the large intestine, or one of the most obvious might be appendicitis, because the appendix is located in that area. However, once those symptoms, or the potential cause of those symptoms, in medical terminology, etiology, would come out, it would be filtered with the patient's own medical history. And lo and behold, this patient 6 years before had their appendix removed. So it is not the appendix, unless there was some error in the surgery and a part was left in there or whatnot. But this would rule out appendicitis as one of the causes. Okay, now I was told, going back to me again, I was told that, let's finish up with the system. So the result will be that the doctor will be provided with the results of this questionnaire, this filtered questionnaire, before the visit. And the doctor will be able to more quickly zero in on what to do with the medical visit, because the computer printout will provide suggestions for how to conduct the visit. You know, for example, doctor, in your physical examination, don't forget to examine this part of the patient and do it in such a way. According to the patient's symptoms, the chances are that these symptoms can be caused by A, B, C, D, or E. Or, and the medical tests that are indicated are tests 1, 2, 3. Okay, so this will give the doctor a head start on his visit. Plus, it'll act as basically an advanced second opinion, so that the doctor should feel more confident that not all the burden is on the doctor, because the computer has taken a lot of this burden from the doctor. Now coming back to my situation, I was told by several different of my doctors, and I've had hundreds of them, that I probably saved my own life at least more than once by becoming knowledgeable in relation to my illness. Now, I'll give a caution on that, because medicine is one area that a little bit of knowledge can truly be a dangerous thing. You've got it's very fashionable now for a lot of medically related people to tell you you've got to learn things for yourself. Excuse me, and you've got to know for yourself. But you have to have a certain base amount of knowledge for this to be effective and not to be counterproductive. Because it can really be a problem to yourself as the patient and the doctor if you come in and have a misimpression and insist on just one aspect of an illness. Medical students go through this phenomenon. I don't remember what it's called right now, but it's a phenomenon in which, as they learn about the different illnesses, they think, oh, I've got this, or oh, I've got that. And it's very common. So this relates to this. It's very easy to misinterpret or misconstrue the significance of a symptom. Let's take one example. Tell me what this is. It has 2 arms, 2 legs, it talks, and it has a beard. What is it? Well, most of you are going to say it's a man. Well, in most cases it would be a man, but it can also be a woman with a hormonal problem that has a full beard, right? So, anyway, you have to be very, very careful. There's a lot of different things that come into play here. Now, one good way to understand how easily we can be misled by different symptoms or phenomena, things that we see or hear, is the movie The Man with One Red Shoe. So if you have a chance to see this, I think it'll be enlightening to you. I'm going to tell you one incident from my own past regarding medical disagreements. It was 1998, and I had dozens and dozens of interventional radiology procedures where the radiologists would go in and would use balloon catheters to expand these areas in my liver. Now, these procedures had been keeping me alive, and I was treated by some of the finest physicians in this area. Top in the world. Creative, dedicated, just wonderful people. However, here I am in this one situation, and I'm getting close to needing a transplant. My liver's not it's failing at this point. And two of these fine interventional radiologists say, okay, you've got strictures or areas of impasse where the bile ducts, which are like tubes, have closed off. And here and here and here and here. They used to discuss these things with me. And they said, we can go in with balloon catheters and we can balloon these out. A few minutes later, they came in all upset. And they said, well, you better talk to the person who was the acting head of the department. He came in and he said to me, well, I'm sorry, but there's nothing more we can do for you. And then they came back, the man and the woman that originally talked to me, and they said, what you've witnessed is a disagreement in medicine, a medical disagreement of opinion. So I was lucky in that I came out to the East Coast and I went to another very, very fine interventional radiologist who, by the way, is very underrated, but is one of the finest people I've ever met and has every bit as much talent, as far as I can see, as some of the greatest names. And you'll find that a lot, not just in medicine, but in other areas. And he performed these procedures on me and probably gave me enough time to survive, because just before my transplant, there was a shortage of available livers for about 6 weeks, and I was going downhill rapidly, and it looked like I wasn't going to make it. So it may have been that helped me survive. And then I thought about, why did this head of that department, or the acting head, why did he behave the way he did? And I remembered that, a few years earlier, he had gone in to do some balloon catheterization, and I had a granuloma, a very sensitive granuloma, like an overgrowth of raw skin almost. And when he first entered the site, I jumped and I said, "Ow, what do you want to do? You want to, you're trying to hurt me or something, or you're going to kill me like that." And I guess his attitude toward me changed. And maybe he never forgot it. Or maybe it was an honest opinion. See, I don't know, but I can always wonder about that. So, and let me add one other thing at this point. I had this very rare non-contagious condition. And I spoke to the permanent head of the department about this. And this was about 8 years after he started treating me. And I said to him, well, you once told me that you've got more of these patients than almost anybody else. I said, how many others did you have? He said, only about 5 or 6 others. The Mayo Clinic was actually the place where they were monitoring more of these patients, even though they weren't treating them directly in most cases, but they were monitoring more of these patients around the country, maybe a couple hundred cases, that's all. And I said, well, how are the others doing? And he said, well, they're all dead. They're all long dead. And I said, well, how come I'm still alive? And he said, I was able to do on you procedures that I couldn't do on the others because you would never complain. And it's true. I would just keep my mouth shut. I would feel like screaming. I would feel like complaining in the worst way, but I just kept my mouth shut. And he'd go, patient, and I'd just go, no, doc, keep going, doc. They'd have staff members. Well, that time, I don't know if this was sexist or not, but they'd have female staff members holding my hand. And they'd have to switch because I was squeezing so hard and I'd hurt their hands. And then I was in such excellent physical condition. I mean, there were a few times where I'd go into the hospital and the nurses would say, or the other members of the staff would say, oh, it's the patient who's not a patient. And doctors described me as a strapping, robust man. And then I heard doctors talk about me. Oh, you could, he's a nail. You could light a match anywhere on his body. Stuff like this. So I'm not saying this to boast, because I'm certainly not in that kind of shape anymore. Believe me, I'm far from it. But I'm just saying how important physical conditioning is to surviving severe medical crises. Time after time, I would read in my files, the patient survived, the patient tolerated the procedure unexpectedly well. After my first 11-hour surgery, no, it was a 6.5-hour surgery, the doctors told me, oh, you'll have to be in the recovery room at least for one day and whatnot. And a few hours later, staff comes over to me, and even though I'm feeling horrible, they say to me, you're doing too well, we have to take you out of here. They put you in the regular rooms, that kind of thing. So, I might just throw that in, how important that is for survival. Now, let me give you another example, going back to what seems to be apparent and what does not seem to be apparent. Okay, I've got an open-ended bucket here. Okay, so it's a bucket. You can't see through it. Top is open, and the bottom is taken out, so the bottom's open. And pour water in the bucket. We analyze the water. We pour water through the bucket, and on the bottom we collect the water, and we analyze that. And lo and behold, it's the same. The water is the same in our analysis when we pour it in and when it comes out. Now, here's my question to you. Does that mean nothing happened when the water was poured through the bucket? Well, the answer is we don't know. We really don't know. The water, I'm going to use a kind of an absurd example here, but the water, let's say, turned into tomato juice while it was going through the bucket, and just before it came out, it turned back into water. We don't know, because we don't know what happened in there. See, anyway, so just kind of an absurd example, but just to give you an idea that it's very hard to know what's really going on. And you'll find that in many areas of life. Now, at this point, I'm going to provide a way or a suggestion on how we can implement this program that I'm proposing. Now, I've spoken to, I'm not a computer, I'm not exceptionally adept with computer knowledge or programming or anything like that. But I discussed this program with quite a few different experts in the field. And some of them tell me the software is available. And I suspect that it is partially available because there are programs on the computer that do diagnoses. And I've even seen, like, in some of the my older American Medical Association popular books, flowcharts, which are similar to how the computer would analyze these things. But then there's other people that tell me, oh, this is way too big a task, because you have to have a separate program basically for each different illness. And there are so many different illnesses. There are, I believe, hundreds of types of arthritis, hundreds of types of cancer. And even of the different types of cancer, there are different variations and that sort of thing. So let's take the worst case scenario. Let's say we need a tremendous amount of work for this. So my proposal would be the following. There are, in the world, thousands of institutions of higher learning, of graduate schools and colleges. And there's some very fine research universities in the United States and Canada, members of the Association of American Universities. And then around the world, there are wonderfully fine research institutions. I'm just going to name, I hope I don't insult anybody, I'm just going to name a few countries that come to mind. England, Scandinavia, Sweden, the Netherlands, France, Germany, Australia, Japan, China, Indonesia, Spain, Portugal, just many, many places, all right? Israel, some of the other Middle Eastern countries, many, many fine places. All right. Now, my proposal would be to have like a central clearinghouse to coordinate the different research. So let's say, for example, let's say just off the bat that we would need 10,000 different programs to make this thing viable. Or maybe more. Well, you can have professors assign one program to one student, let's say. Okay, in the United States, in 1 year, there were something like, this is just off the top of my head, like 1,400 PhDs. This is just a few years ago in math, and about 8,000 or a little less than 8,000 PhDs in the in the sciences, in the biological sciences, I believe. So these students can be urged to become involved in a project like this. Then there's thousands more students that have to do senior theses. And a lot of times the professor has a lot of influence in steering people in this direction. This is important because we're no longer at a stage where we have the luxury of doing research that's not practically oriented. That's my opinion. When I first entered graduate school, and I went to what was at the time rated as the top university in the United States. It wasn't Harvard. Harvard was rated number 2 at the time. My professor said to us, well, there's 2 kinds of research. There's directed research, and then there's pure research, research for the sake of research. And they said, well, a lot of times this pure research comes up with significant contributions, and I believe it does. However, I think that the world is so emburdened with different problems that we need to focus research in a problem-oriented manner. So, anyway, this is my feeling about it. And at this point, I would say that I would like to throw out a challenge to some of these great and wonderful philanthropists. Warren Buffett, Bill Gates, Ted Turner, many of the wealthy billionaires. I think his name was Jeff Skoll that I saw the other day on 60 Minutes. These are wonderful people, and of course I'm not naming, a fraction of the great philanthropic people. Challenge them to help fund this stuff, to fund organizations that will implement these solutions. And as the billionaires that were interviewed in this 60 Minutes piece pointed out, there's a big learning curve. There's a lot of learning that has to be done. So, even with the program that I propose, I would say that you would do what is normally done in research, or what is done in a lot of the WISE research. Have a pilot study. Try it out first on a smaller scale and see how some of this would work out. Okay. Now I didn't mention a certain aspect of this program that I think should be mentioned, and that is that I believe there should be what are called mobile cardiac